So I wanted, Dr. Atri, as I was listening to you, one thing I didn't mention, the Alzheimer's Association is sponsoring the Hope for Alzheimer's Act, Health Outcomes Planning and Education. And one of the things that it does, it changes Medicare reimbursement for a full workup for the differential diagnosis of dementing illness. It requires that the diagnosis be entered into the patient's record, and it pays for one planning conversation in the medical setting. So it can be done by the doctor, a nurse, a social worker if they're around. But, and we think that this would start to move this issue of diagnosis. So a question for either or both of you. We know that over half of the cases of Alzheimer's in this country are not diagnosed. And there was a study a year ago that said when doctors actually bill Medicare for Alzheimer's treatments, over half of the time in that case, they don't share the diagnosis with the patient or the family. Why?
Well, it's interesting. There are multiple reasons. So there are patient and family-related reasons. There's clinician-related reasons. There's healthcare-related, system-related reasons. But it's really interesting. Imagine if you were on chemotherapy and you went to an oncologist and you were on chemotherapy and they said, well, what's this? I said, well, I was given this medicine. They said, there's some growth, and they gave me this medicine. It was chemotherapy. Now, wouldn't that be shocking? That would be shocking, right? But guess what? People come to us all the time. They're even on Alzheimer's medicines sometimes, but they're not given the diagnosis. So, it is prevalent. It is unfortunate. Our system is not set up to reimburse caring for people.
But why do you think a doctor wouldn't tell the patient or dig into it?
Well, I sort of have two thoughts. One is, and this is not the direct answer, and that is sometimes physicians will give some of these medications approved for Alzheimer's disease off-label. So there's some memory problem, they'll give an Alzheimer's medicine, and maybe then the assumption is this person has Alzheimer's disease, but certainly not, it's not being diagnosed as such. So that might account for some of it, but certainly not all. I think other times not telling is wrong, but sometimes not irrational. In California, the mandatory reporting laws, for example, related to driving. Someone that has a diagnosis of Alzheimer's disease or another form of dementia, healthcare providers are required to submit a form to the local health department, which then goes to DMV, and some people would rather not deal with that, think that maybe the patient shouldn't lose the autonomy involved in driving, although license revocation is not automatic, and it can be appealed, and it can be. I have a number of patients who have Alzheimer's diagnoses and still drive. In other times, I think it just takes time to talk to the family and go through the issues, and some physicians don't have the time, and some physicians don't think they have the backup resources in terms of all the caregiving issues and other resources are required, and they're just lazy.
So I agree. When I said we're not reimbursed to care for people, it's exactly that. They're not set up to have the resources to actually, when you if you're going to do it right, this takes a lot of time. It takes counseling, it takes repeated visits, and some of them don't have the knowledge, they don't have the confidence, they don't have the resources. And even if things are mandated, then unless we have people who have the resources and expertise to do it, it's not going to help us.
So, lots of questions here. Sleep medications in Alzheimer's disease. What's the relationship, if any? Sleep medications and Alzheimer's.
Go ahead.
Well, I think you addressed that during your presentations, that although there are sleep disruptions with aging, there are more sleep disruptions with Alzheimer's disease, and it's a problem, it's an issue, and caregivers need the rest. They think that patients need the rest, and sleep medications are used, and they're overused. I think in general, sleep medications should be avoided. They have other cognitive carryovers the next day. They affect balance and gait. And to the extent that sleep disruption is not hurting the patient, and often it's more the caregiver than the patient, I think in general they should be avoided. That doesn't necessarily provide an optimal solution for what people have to deal with. Sometimes behavioral interventions can help in helping patients stay through the night, but there's no optimal solution.
So I agree. It turns out that, when you look back at when people get diagnosed, and you look 1, 2, 3, 4, 5 years, and particularly actually people who are young that I take care of, young folks, and sometimes 7 to 10 years beforehand, what you see are changes in mood, sleep, anxiety, depressive symptoms, and people get put on a bunch of medicines for this stuff, and yet other stuff goes unrecognized, and there's actually a fair bit of literature that when you take these medicines that are anticholinergic and bad for you, and now actually there's evidence through even imaging that when you look at folks who have amyloid in the brain and get these medicines, guess what? They progress faster. So they're not benign by any means. But the solutions, again, are complex in the sense that you have to sit down and explain to folks that, well, you know what, if there's sleep disruption, you need to keep the patient active during the day. And you have to do sleep hygiene, and you have to do X, Y, and Z, and that takes time to do. And again, so God bless the care coordinators and social workers who spend a lot of time educating folks, because those effects are just as much as deleterious as our medications are efficacious.
Several questions digging further into the amyloid hypothesis. And the question is, what is amyloid's healthy function, if any, in the brain? And then talking about the amyloid hypothesis, is it a result? I think you addressed this a little bit, but is amyloid considered a result or a cause of Alzheimer's?
So we don't know the exact function of the normal amyloid protein. So it comes in a precursor form. It gets cut by these enzymes that I showed you. And you can get these A-beta 42 form that is kind of sticky and destroys, basically synaptotoxic to the synapses. So we know it's somehow critically involved. We don't know if it's the cause or not. And the hypothesis has been if we do something about it, it's going to change the clinical course. We're learning that when it's late, it doesn't. Some of the research into what regular amyloid does, they think it's important in memory and learning somehow. So it's in areas that are more active, and it seems to be involved in that. There's some theories that actually it at some level it's dampening toxicity in different ways, but our understanding is incomplete. So I would say the amyloid hypothesis is not dead. It just needs to be tested earlier, and hopefully with these BACE inhibitors, we'll have a little bit more of an answer to the question.
Yeah, and I agree with that. Amyloid comes in the larger precursor protein, and ordinarily people speak as if the certain form that accumulates in Alzheimer's disease is the abnormal form. And in the sense that it is, but it probably also has some biological role, and it's just sort of the abnormal accumulation. And as we're becoming more and more aware that a lot of these neurodegenerative disorders appear to be due to protein misfoldings. So although beta amyloid by itself may be toxic, it also sort of induces misfolding, and that's probably how the disease propagates within the brain. You know from children with Down syndrome, where you have an extra copy of chromosome 21, as adults, they almost all have pathological features of Alzheimer's disease. The gene that makes amyloid protein is on chromosome 21. So there's sort of strong evidence that at least in some circumstances, too much beta amyloid leads to the other pathological features of Alzheimer's disease. But the connection between that and the tau accumulation, the connection between the amyloid accumulation and exactly where the neurotoxicity is and the other cascades of events that occur, that's, after all these years, there are still gaps in knowledge there.
There are big gaps, and we've cured Alzheimer's. So in mice, we have really nice models, and we can take stuff away and they become a bit smarter. But we haven't made that leap in people, just much more complex.
And all these studies that Dr. Atri talked about during his presentation, they worked in mice. Every one of them, or they wouldn't have made it to humans.
Yeah. Yeah. Point. A couple of questions about, you mentioned in one of your slides, Dr. Atri, about a sweet spot for, and the question is there a sweet spot for Aricept? And if so, when would that be? And then a related question that this individual has noticed, I'm going to guess they're a case manager or a social worker, and that they've seen doctors take their patients off of a cholinesterase inhibitor, saying that it's only useful in the early stages of Alzheimer's. But the questioner says they believe they've seen a decline then in function and performance 30 days later.
Yeah, I would say that they're an astute observer who is backed by data. So let me take the second question first. In groups of individuals, there is absolutely no question that if you take people off for groups, they do worse. Okay. So the latest evidence from that is from the Domino AD study in England, where they took people off, and about in year 2000, it was the AD 2000 study, when donepezil, Aricept, was not generic. So the healthcare system in England had to pay for it. And they did this very poor study, unfortunately, that said basically they were taking people on and off, and they were, because of, whenever you give these types of medicines, when you go on and off, you get basically side effects and no benefits. It has to take time. So they were putting people in the hospital. They did all this bad methodology, and they still couldn't wipe away. There was actually some benefit. Okay, but then they said, well, the benefit. A bunch of us jumped up and said, oh my gosh, are you daft? Do you not take care of patients? Do you not see the flaws in this design? It took them another, or more than 10 years to do another study that basically, and if they take people off, it's so that's the answer. So for groups of folks, for at least for cholinesterase inhibitors. As far as where the sweet spot is that's where the art of medicine is. With that perfect data, and I'm a mathematician, so I'd like to be able to say, you can plug in the age and all this other stuff, and you come up with a sweet spot. You don't know. So generally, you start with one of them. You start slowly. You see how, where people, if they eat foods, when they eat food, because some of them, on an empty stomach can make people a little bit, nauseous or have loose stools. Give it during the day, and you slowly go up. And ultimately, it turns out that people do need more over time. And that's why with the cholinesterase inhibitors, initially they couldn't get the label for severe AD. It wasn't until they did the other studies and they were able to finally get the label for severe AD at higher doses. And guess what? When you're giving these medicines at those stages, are you doing it for short-term memory? No. The expectation isn't short-term memory. The short-term memory systems are destroyed. You're basically allowing signal processing to go ahead, and their attention may be a little bit better, the functional communication a little bit may be better. They may be able to retain daily function a bit more, and there may be a lid on behavior. I didn't actually show you the data on behavior, but the data on behavior is probably the strongest.
I think I agree for groups. Absolutely, I think it makes a difference. I think the studies show, in general, people are about 6 months better than they would have been otherwise. This isn't a cure. It doesn't change the fundamental underlying biology in people that have a number of adverse risks. I don't necessarily try to push it and force it on patients, because I think in those instances the side effect profile may be worse than would outweigh the potential benefit. But for patients who tolerate it, and most do, I think it's a common drug. I think on average it's effective, and I agree that discontinuation, although we don't have as strong data as we might like, often turns out to make people a bit worse than continuation would.
What is the role of inflammation in Alzheimer's and other dementias?
It's either everything or nothing.
Right.
So inflammation is a very complex concept. It's not just one cell. It's not just one cytokine. And it's something that goes on all the time. Or, it's an ordinary process. It's an essential process. When inflammation goes wrong, it's a precursor to a number of disease states. So everything from cancer to heart disease, Alzheimer's disease is linked into inflammatory states. So I think it has been for a long time, remains a key area of investigation for a number of the neurodegenerative disorders, and I think it's really an important area. That said, looking at anti-inflammatories in terms of people who already have dementia, the studies that have been done, like so many others, have been disappointing. The underlying biology is there, the observational data are there, the clinical trial evidence is not there. There's always a question, well, maybe a different anti-inflammatory started a bit earlier would have made a bigger difference. Maybe. I'm always a bit skeptical when people keep moving the goalposts further and further and further along. So I think inflammation from a mechanistic point of view still has a lot. There's a lot there that we don't know about. But in terms of rushing out and taking ibuprofen to stop Alzheimer's disease, not yet.
Yep. Any data on turmeric, someone asks?
Yes, but not much.
Uh-huh.
So turmeric is, it's a spice. I'm not a nutritionist. It has some effects in some animal models that seem promising, and the clinical trial data, and I think this is coming primarily from UCLA, was sort of small. I don't think there was a signal that was actually seen in the clinical trial data. Someone correct me if I'm wrong. But then I think the trials were too small really to see more than a really super large effect. And so theoretically, there still could be something there that hasn't been answered by the clinical data that we have thus far.
And a related question, do we see Alzheimer's in different parts of the world at the same rate? Are there geographies or ethnicities where we see more or less these issues?
Well, I'll put on my epidemiology hat. And the answer is yes, but one question always is, are diagnostic criteria the same? So, for example, the total rate of dementia in Japan is similar to what it is in the U.S., but there's more vascular dementia in Japan, there's more Alzheimer's disease in the U.S. Is this because of different lifestyle exposures, different diagnostic procedures, and that's sometimes difficult to tease out. Another aspect of this, and we were talking about brain resilience, cognitive reserve earlier, is that different social groups are exposed to different degrees of vulnerability. So groups where there is more vascular disease, dementia is more likely to emerge in that setting. So obesity, diabetes would be risk factors. Some ethnic groups, some social groups are more at risk from that point of view. Education is thought to be protective against some of the dementia manifestations. So overeducated people from privileged background tend to do better than people that come from more disadvantaged, less literate background. And so there are a lot of social disparities and inequities. The extent to which some of this is genetically related, probably not to any more than a very modest extent, but there certainly are racial and ethnic differences in what is manifest in the real world.
So there are a handful of questions about seeing the pathology early and how soon. So we probably agree from both presentations that we can image amyloid in seemingly cognitively intact individuals today. Where are we with imaging tau? Well, it was in one of your presentations, but what is the state of that right now?
It's experimental. So we have a study right now at the Ray Dolby Brain Health Center where we're actually looking for people who are in hospice. They could have dementia, Alzheimer's, or not have dementia. And the idea is actually to ask for a brain donation later, for them to undergo a tau PET scan, and then afterwards, when they pass, the brain is donated, and they look at the correlation between what the what the PET scan showed and what the brain shows, and that's the same process that the amyloid imaging went through to be verified. So it's at that stage, and so this really important work has to be done to support that the scan, the PET scans are doing a good job of picking it up. But that's very, very exciting. I would say, along with inflammation, there's going to be ligands for PET scans for inflammation also. And like I said, in the future, I can actually, you can imagine where you can actually, be able to characterize in many ways based on your ApoE status, a number of inflammatory markers, your PET scan for, is positive for tau and maybe amyloid, but negative for this kind of inflammatory, that you can actually be able to get a combination of medicines that are targeting things to you. Right now we can get information about tau, hyperphosphorylated tau, but it's actually from spinal fluid, clinically, but otherwise it's an experimental thing.
So if you take this as a picture, and you probably both agree, we know the pathology of Alzheimer's is starting to be present in the brain 10, 15, maybe even 20 years prior to the evidence of dementia, which is the way we still define it today. So I remember, 12, 14 years ago, Florazan was a compound that was talked about. Looked, as you said, looked very promising in phase 2, disappointed in phase 3. And I heard a researcher presented this at what we know as the Alzheimer's International Conference today, saying, well, but don't throw it away, because the problem was we mounted this trial by definition with people who were too sick. And if we could have introduced it possibly earlier on. So that's what I'm really asking. What's your vision of whether it's PET scans or spinal fluid or blood assays, hopefully at some point, things that are obviously cheaper than PET scans, which are very expensive now, but the ability to mount trials and test things in people who are functionally pretty intact, but have the pathology of Alzheimer's. Should we be hanging our hats on this notion of biomarkers?
Well, if we've learned from other fields, then the answer is yes, right? So we've learned, if we've learned from, we don't wait in some ways until somebody has the heart attack or their stroke to treat the hypertension, which is a biomarker. So, high blood pressure. It's an easy biomarker. You can just get it this way, right? Or we don't wait for people, to have to actually have diabetes if they're already, you're seeing the blood sugars are creeping up and, A1Cs are creeping up, then you want to, institute lifestyle modifications, other things earlier, potentially. So I think we've learned from other fields. Osteoporosis is another one. It's just that, yes, the brain is very, very complex, and we've been woefully underfunded, and we need to do these studies for years to come, and I think we'll be able to do better.
So I think biomarkers have their use and their misuse. I think they're very important in selecting subjects for clinical trials, and that's something you addressed in your presentation. If you have a drug that's going to remove amyloid from the brain and you have a good biomarker like amyloid PET to indicate whether there's substantial amyloid in the brain, and those people don't have amyloid, then they're the wrong people for the study, they're the wrong people for the drug. They dilute the effects of the drug if there were any there to start with. On the other hand, biomarkers are just that. They're markers of an underlying clinical condition. They correlate imperfectly. No biomarker correlates 100%. Sometimes biomarkers are within the causal pathway. Sometimes they're a little bit more peripheral, or they're other causal pathways. And so it becomes a little bit of a different issue in deciding how to use biomarkers clinically. As Dr. Atri said, a lot of us will have amyloid in our brains if we were to undergo amyloid PET imaging now. And by and large, I'd rather not have amyloid in my brain. I don't think it means a good thing, but we don't actually know how many people at middle age, at younger, older ages who have amyloid will have dementia in 5 years, or 10 years, or 15 years. Certainly the risk is there, but the clinical certainty isn't there yet. So in that sense, I think we have to be very careful about how we use biomarkers in a clinical setting, but in a research setting, they absolutely make things a whole lot better, a whole lot more useful. And once we have effective forms of intervention, then it makes good sense to check your brain amyloid the same way it makes good sense to check your cholesterol. Having cholesterol doesn't mean you'll have a stroke, but it does make good sense to lower cholesterol because you can do that. Having amyloid may or may not mean that you'll get Alzheimer's disease, but if there's an effective way to lower that, then that would be the time to start moving biomarkers more into the clinical setting.
So I would say, so I agree. I think the idea of having multiple biomarkers, some biomarkers are used for certain things. So amyloid is useful for saying that you have a trait, you have a higher risk state potentially. But as you notice, it saturates very early, and then stays up. So it's not a good one to sort of, monitor your clinical status. So in the same way that, for example, let's say for cholesterol, you may have high cholesterol, but then another biomarker may be, they are looking at your carotid arteries and they start seeing plaque, for example. So now there's actually damage in some ways or accumulation. So over time, you can imagine you can have one thing saying, well, your amyloid is high, and you check and you say, well, now it looks like your tau is accumulating. And now it looks like, based on this fMRI or PET scan, there's actually changes in synaptic networks in the brain. Are you going to wait until you actually have brain shrinkage to do something? Probably not. So again, my point is that probably multiple biomarkers we need to study and understand for many, many years. And I think in that way, ultimately, I think we'll be able to use them clinically. But yeah, we're not there yet.
Well, I've got the 2-minute mark here. So one quick question, I think. You mentioned vitamin E, Dr. Atri.
Yep.
What level, someone asks?
Yeah, so 2 studies. One, 1997 was the Alzheimer's Disease Cooperative Study, Mary Sano et al. Another one from about 2 years ago, Diskin et al. Through the VA. Both of them used a high dose, 1,000 units twice a day. Why 1,000 twice a day? Because it needs to be high to get into the brain. It needs to be twice a day because it falls. What did I give my father? I gave him 800 twice a day. Why? I used to give him 1,000, but the pills are really, really big. And the 400s, I give him 2 400s that are little. And basically, there's 2 clinical trials now that are randomized that go on for several years. They've had the same marker, decrease about 19% compared to not taking it in daily function. And then there's actually a whole bunch of other observational studies, et cetera. So where you had bad things came out about vitamin E was about 10 years ago, there was this meta-analysis that hit CNN and everyone else that vitamin E is bad for you. And they took apples and oranges and they took peaches and combined them in a whole bunch of 30 studies that were not related and weren't even meant for that. And then they said, high dose is bad for you. Actually, in all of them, 150 units or so gave you a mortality benefit. If you look at the Alzheimer's patients in that study, it was in one little corner, and they didn't actually have a decrease. They did not have an adverse effect for mortality. So based on those, you kind of look at the risk and benefits. I look at people at their MRI, if they haven't had microhemorrhages in their brain, if they're not on Coumadin, if they haven't had a lot of bleeding or bruising, then I suggest it.
And Dr. Henderson, relationship between MCI is the theme. And should people be involved in risk reduction strategies if they've been diagnosed with MCI? Are there things to be done to keep it from converting to Alzheimer's disease or another dementia?
So with MCI, there's always some uncertainty in the diagnosis. It's a clinical diagnosis. Dementia essentially is a clinical diagnosis as well. And often when we see a pattern that we think indicates early Alzheimer's disease, we'll be right, but we won't always be right. And so, that needs to be taken into consideration. There are a number of studies that have been done now looking specifically at MCI. I don't know that any of them have really shown something that's been proven to be effective yet. On the other hand, we don't have a lot of data to go by. And I think the kinds of things that we talked about for cognitive aging would also apply here. So I tell patients, and I indicate that the level of evidence isn't as strong as I would like it to be, that I do encourage regular aerobic activity, 30 minutes a day, 5 days a week of brisk walking would be one example. I do encourage good nutrition that includes fish that are high in omega-3 fatty acids, but are part of a regular nutritional diet, social engagement, mental activity. And beyond that, those are the kinds of things that I mentioned. And for mental activity, I specifically say it doesn't have to be a computer game, but if you go out and you paint, you spend time with your grandchildren in an engaging way, you're reading, you're doing, I think all these various forms of mental activity probably have the same level of effectiveness.
And the final question. There's several questions, and I think people sometimes listen to what we say and they come away with the notion, although it's not what we're saying, that there's a test. And so that's what I want you to address. That is today, right now, if you're the worried well, and you're in this room and you're concerned about your cognitive status, is that what test is available?
I had someone the other day saying, well, I'm going to send my saliva sample into 23andMe. Is that a good idea? What's the state of test available for someone concerned about developing Alzheimer's-related disorder?
If you have a very strong family history, there are some very specific tests for autosomal dominant mutations associated with that, but that probably fits nobody in this room. It's
Because it's statistically rare.
Because it's statistically rare, and for that reason alone. I think otherwise, most people who are concerned about having dementia don't. That said, with mild cognitive impairment, with people who later go on to develop dementia, there is some awareness sometimes that memory is impaired. Surprisingly, sometimes there's a complete oblivion to that as well. On the other hand, people who are concerned about memory are much more likely to have some mild underlying depression than to have preclinical Alzheimer's disease. Just because you think that you're not quite as good as you were 20 years ago, well, you're right. In terms of memory, not in terms of wisdom, but in terms of being sort of an early manifestation of Alzheimer's disease, maybe, but probably not. It's sort of easy to overdo it.
So I would say live life. You can't, if you waste today worrying about the future that may not happen, then you're just wasting today. But do all the things that are low costs, which is get some sleep and get some exercise and eat well and be engaged. All those things are very, very important. Come join a study. Come join our studies and be followed over years and do that kind of stuff. There is unfortunately data that subjective cognitive impairments, particularly in people who are bright, are not nothing. They actually, if you follow some folks, some people become a bit more aware of their changes earlier than other folks. And if you haven't had depression all your life and suddenly there's major issues with depression, anxiety, sleep problems, those are actually very sensitive networks in the brain where the chemicals are being altered because of neurodegeneration that may be due to Alzheimer's or vascular changes. It may not be nothing by itself. So, so those are still markers of risk. So be active, be empowered, and do something about it. And if we're lucky enough to get into our 80s and 90s, unfortunately that goes with the territory. But until then, be strong and be empowered. Okay?
Dr. Victor Henderson, Dr. Ali Atri, thank you very much.
Thank you.